Umeo, that is you. That's really
Umeå
good.
University.
OGM really rocks now. Okay.
Okay. Now it's time to our third session, Sunny. So this session will be a promising strategy for the health sector that guided by Professor Hari Kusnanto as moderator. So for Professor Hari Kusnanto, please.
Thank you. And this must be a very difficult time because all of the blood flow, almost all are allocated to our digestive system. But somehow we will have very interesting talks from Dr. Asa Homner-Roklov, from Dr. Lutfan Lazuardi, and from Dr. Widodo. We still expect him because he lost his way to the university, to the main campus, but I think he will be here soon. But first, I would like to invite Dr. Asa Homner-Roklov to come to the stage to present your paper. And first of all, I would like to introduce Dr. Asa. Is now working as a researcher, biomedical engineer, and informatics at Umeå University Hospital. And of course, she is doing a lot of work with other partners, including with Gadjah Mada University. She graduated from Chalmers University Technology, Department of Molecular Biotechnology in 2005, and Masters of Science in Institute of Technology from Linköping University in Physics. And she has a lot of experience, quite broad experience in biomolecular and biotechnology, biophysics. Amazing. And also her publications. I'm interested in one, crystallization and preliminary X-ray crystallographic studies, because my professor, Thomas Steitz, crystallizing ribosome, got Nobel Prize in 2009. So I think it's, the way is open for you for another Nobel Prize, because it's not far from Stockholm. The Nobel Prize is awarded in Stockholm. So hopefully, because you are so productive researchers, and I think you will share to us very interesting issues in eHealth and mitigation of climate change, of course, in the health sector. The time is yours.
Now I'm an engineer, so I could figure that one out. So you're embarrassing me. I have a broad background, but that is not typically something I see as positive, but thank you. And I have to disagree with Nawi and agree with you that this is the worst time of the day. So before you fall asleep, I was thinking of not counting, but we have another exercise for you, and that's the 3 Swedish letters O, Ä, Ö. So come on, speak with me. O, Ä, Ö. So now you can all pronounce my name. Åsa Holmer-Rocklöv. And also you, Harry. Okay, so as you see from my title, it also says CC Map Outcome Report. That means that I'm going to talk a little bit more about the results from this project, together with the reports we've been hearing more from earlier today on the policy, but this is more towards the technical aspects of the project. And I must say that I'm quite happy because I'm not going to have a problem to keeping my 20 minutes, which actually hasn't started yet. Thank you for that. because all the previous speakers have introduced some of my first slides already. So just as a reminder, what are we talking about when we're talking about mitigation and adaptation? And that is, mitigation in climate change is not like you use it for mitigating risks or well, it is a risk, but it's used in the way that we mitigate climate change, reducing the carbon emissions or other greenhouse gas emissions to prevent continuation of climate change. And adaptation is to increase the resilience of people and society. And adaptation can be it's autonomous. That's something we do without thinking about it, or it could be planned strategies launched by different parts of society. And also when it comes to the concepts of eHealth and telemedicine, I think you are quite informed. I'm going to focus a little bit on telemedicine, which is not something we have covered today. But in this project, we are looking into many different kinds of ICT technologies for climate change mitigation and adaptation. And just to group some of these activities, we are performing a systematic review on how telemedicine has been used in disasters previously. And sadly enough, these are increasing, and we are going to have a growing bunch of research to learn from. It's good in one way that we can learn from how this has been used in other cases and other places in the world. But I also have to say that it's sad that we have to do so. And the other thing that is also within adaptation, because this is telemedicine in disasters, is something we can see as adaptation, how to prevent casualties and improve the healthcare. And we are also doing a disaster simulation tomorrow. I think Maria mentioned it also. And this is something that I'm really, really excited about, because this has been such a fantastic engagement from the region on this. And there's a lot of civil participants that are going to be there as casualties, and I actually offered to be there, painted like a bleeding poor tourist or something, but I think I'll probably be more documenting. But this is also something we're going to use to go into, dig into, to see where could this preparedness actually be improved. Where can we use this kind of technology to strengthen the system, to make it less vulnerable, or to be more prepared and more efficient in the first response after disaster to save lives. But what I'm going to talk about the rest of my time on this stage is a life cycle assessment of telemedicine solutions, to estimate what is the potential of this type of technology to actually reduce emissions in the health sector. And unfortunately, depending on how you see it, this is something that we are just about to publish. We are waiting the reviewer response, which means that I can't share any specific details with you. But feel free to come to me and we can discuss it afterwards. I'm not allowed to show it in print. And first of all, I want to share with you a country that has come very far in looking into what kind of mitigation potential there is. The national health systems in the UK have been characterizing all parts of their activities to see where we can actually reduce our carbon footprint. And this, I think, is a very good message, because most people tell me, well, sure, telemedicine, but what about energy consumption? The thing is, we need to look at all different parts of the health sector to actually make a difference. And if you look at this picture over here, I think if I can find the right one, no? If they only look at, can you actually see the pointer? No, not even I can. So if you look at the first point 1 and 2, I'm sorry that the type is so small, but it says refurbish buildings or replace buildings. So of course the hospital buildings are big emitters just by the fact that they are consuming so much energy. But if we only do that, you can see on this curve that maybe we can keep emitting in the same frequency or same amount. But if we add on all other types of strategies on top of that, that's when we can actually make a big difference. And if you look at the different points here, refurbished buildings, less travel, less medtech, procurement and so forth, and model of care, I would say that telemedicine falls, of course, into less travel emission, but also the model of care, because this is a new way of treating people. And travel represents, if these figures are approximate, and I would say that's probably similar in Sweden, but nearly 20% of the health sector emissions come from travel. So, down to our study, we have been working with telerehabilitation in 2 different units in the hospital. One is the speech therapy unit, providing speech therapy to people of all sorts of conditions, people suffering from stroke and aphasia, speech impairments in children, and so forth. And then it's also the hand and plastic surgery section, where they are doing a lot of rehabilitation after different types of hand injuries or surgeries. And just to give you an idea of the distances we are actually bridging, this is Umeå. The university hospital is down here. And we have patients in the whole northern healthcare region. I didn't like that this one didn't work. So this whole bluish area, including Västerbotten, is part of the northern healthcare region. And this is about, correct me if I'm wrong, 1,000 kilometers, maybe even more, 1,200 kilometers. So we are covering a huge area with specialized healthcare. And in these particular cases, what is also a little bit special is that many of these treatments are provided in the patient's home or in the nearest primary health centers, but many of them in the home. And the method we are using, there are some studies, I should say, that there are some studies performed in other countries where they have looked at travel emissions or reduction in travel emissions, but then they disregard the fact that information and communication technology itself produces carbon emissions and other types of pollutions. So what we wanted to do to add on to this concept was to do a life cycle assessment, where we look at both the kind of emission that is produced during the use phase, which you find down here, but preferably the whole chain of events from a product's starting point to when you actually discard it. And if someone is awake enough, you're going to say, well, computers are not made out of wood, but that was just for convenience. It was easier than having a mine of some sort to show you how to extract the material. But initially, the concept is based on the fact that you look at what happens, what do you emit when you extract the raw material, when you process it, when you transfer it to the factory where you build it, you transfer it to the store where you buy the stuff, you look at the whole life phase when you use the equipment, and also what happens when you throw it in the trash can. And hopefully, if we have a good system for recycling, you can actually feed it back into this chain. And naturally, in order for us to make this correctly, we have to do this also for the alternative case, which is when you actually travel to the health center or to the specialized clinic. So what we start by doing when we have identified the clinics that we are working with or the cases we want to study, because these could of course be hypothetical cases, we look at what kind of technology we have to use. And in this case, these 2 clinics are, or the activities are based on simple video conferencing solutions. So no additional technical tools are used. So we look at the video conferencing peripherals, and by that I mean the computer, the loudspeaker, web cameras, but also the components in the network like switches and access points, routers, so forth. Then we look at the use rate. How long do we actually use this equipment? Is it for 1 year, for 5 years? Do we use it 5 times a day or 5 hours per day or 50 hours per week or just 2 times a year? And we also look at the bandwidth requirements, because you have to remember it costs energy to send data. And then, of course, we need to look at how many appointments can we actually replace and how far would this patient have to travel if we didn't provide this option. And then we do the same thing for the travel option. We look at the distances, what do you actually use to get to the clinic? Do you use a car or a bike? And if you're traveling 300 kilometers, you can be pretty sure it's not going to be on a bike. And most of these patients are actually going by subsidized taxi services, so we have been calculating what would the emissions be using a car. And then also, since we have the life cycle perspective also here, we look at the cost of actually producing the fuel, using the car, that is the tailpipe emission, but also going back to the manufacturing stages, road infrastructure, and so forth. And down here, I have written down 2 references, and that's because I'm going to show you in the results that we have a slightly different estimates. Are you still awake? Do you remember how to pronounce my name?
Oh,
Ah, impressive. I have to check because I'm about to fall asleep myself. I'm really impressed. Okay, so let's go on. Oh, okay, so simple enough. We all know the plus sign. We add one thing to the other, and we see how much do we actually produce during all these telemedicine appointments. And on the other hand, look at, okay, what kind of emissions would we've had if we had gone to the appointment, just our normal everyday way of treating people. And there's one more thing to keep in mind. The one thing was the use phase, but what about the rest of the emissions generating? What do we do with that? And then you amortize it over the whole lifetime. So that's why it's important to think about how often do we actually use the equipment. So up here, I just you have some abbreviations down here that you have manufacturing, distribution, end of life stages is what is typically looked at. But then you amortize that, so you divide it with the life length in hours or days, depending on how you're calculating. And I think you already know that it's going to look like this. Otherwise, I wouldn't be standing here. That we have a lot of much more emissions by this traditional way of traveling to the appointments. But how much? And again, I'm sorry for not providing you with figures in carbon dioxide equivalents or similar, and that's just for the publication reason. But as you can see, there's a very, very big difference. And just to explain the picture a little bit, here I've written lower bound and here upper bound. And the reason for this is that we are using different technical logical setups. And as you can imagine, having a very advanced video conferencing equipment with big screens is going to consume more energy than if you have a simple Skype solution on a desktop computer. So I've been looking at these 2 a little bit more extreme cases to see whether it's going to make a big difference or not. And then I have compared it with the car travel using 2 different references that are addressing a little bit different aspects of LTA analysis, and also this one to the left down here is also a little bit newer reference. But even when comparing to the goal, the European goal of how much a car is going to be permitted to emit in 2015, we still reduce the carbon emissions by 50 times, up to 100 times. So it's not like 2 or 5 or 10 times. It's actually a really, really big difference. And to look at these factors, deciding whether it's going to be a low-emitting video conferencing situation or not, when should we actually use it and when should we not use it, then we performed a sensitivity analysis. So we keep all other factors constant and vary one at a time. And this is what we found. Of course, the meeting duration, because we're going to have an hourly emission in our calculations. If you use the equipment for 2 hours, you're going to have twice the emission during the use phase because it's only emitting due to energy consumption that is using the energy. So as you see, you will essentially going to have 8 times as much emissions in an 8-hour meeting compared to 1 hour meeting. But the most exciting thing, at least for me as an engineer originally, is that the bandwidth made such a big difference. And these are global estimates of the energy intensity of internet traffic, so it might be different in different countries, but we are trying to use the upper estimates to make sure we don't underestimate the emissions we actually generate using this technology. And that means that if you go from these video conferencing solutions that we use in the patient's home, might end up somewhere like 768 kilobit per second, or maybe, depending on where you live, if you have a very good internet connection, maybe up to 1 megabit. But then there are situations where we meet at the primary health center where we have the capacity to go up to maybe 2 or 4 megabit per second, and then you're going to double, at least, the emissions. And use rate is going to be influential in some cases. Here, if you see the baseline is green, you can't actually see it. But if we increase the usage, of course, it's going to be less and less emission from these other life cycle phases for each meeting. So basically, if you don't use your equipment a lot, you're going to have more contribution from the other life cycle phases. And then maybe this is the most relevant question. Again, sorry, I'm not going to print any exact figures, but let me put it like this. You could see we had very long distances, which means that we are making this really, really big gains from using this technology. But already in a city environment, I would say that you could actually benefit from connecting to your health center or hospital using a computer instead. You don't have to travel more than a couple of kilometers by car in order to make it a more green choice. And then again, if you have a very big conference room where you also have to heat it, or in this case, cool the room and add on these different aspects, you would have to be a little bit further away. But considering also the fact that whole benefits of reducing the need for traveling in cities, if you look at accident, air pollution, I would say that this is the best solution would actually be in the cities, because here it's quite natural in rural areas to start using this technology, but my take-home message is that this is equally beneficial in cities. So some conclusions from this study. Especially in Västerbotten, this telemedicine or the telerehabilitation is a very potential carbon reduction strategy for the health sector. But I would also say that we could claim that it's going to be a good strategy also in urban environments. The main factor contributing to the carbon footprint of these video conferencing solutions is going to be the meeting duration and the bandwidth, but also the choice of technology, that if you're going to reduce the emissions as much as possible, it's good to build on simple video conferencing solutions, using computers you already use in everyday life, and so forth. And I would say that telemedicine should be recommended as a first-hand choice for short and frequent meetings. So, of course, we are not replacing the meeting with a specialist nurse or doctor or physiotherapist. You're always going to meet him or her. But if you need frequent treatment to, for example, to come back from a stroke, then having the opportunity to perform your treatment at home intensively for many, many times a week, the treatment outcome is going to be so much better. And you can also have very short meetings without having to travel anywhere. And of course, if we want to look at this in the long-term perspective, I know we had a question previously today about cars, whether cheap cars is a good thing for us or not. And I would say that maybe the first thing to do in Georgia, being here for quite some time this year, is to reduce traffic. It wouldn't be telemedicine. It would try to get the people off those motorbikes and go into a good public transport system. So we have to take that into account. And I also want to stress that if we want to invest in this technology, it's good to think about where to place it. If we want people to use it, it has to be in a convenient place. And we should think about whether the best situation is to have very good desktop PC with a good webcam, because there's always one person connecting, or whether it's actually good to have a big conference room with room for 20 people. This is something it's good to consider. And I think that was what I was about to present today. So I leave the floor to the next speaker and looking forward to all your questions. Thank you.